Baby with VSD, 8 AMM, respiratory distress, pulmonary hypertension, treatment, catheterization, and urgent operation. Whenever there is development of pulmonary hypertension, there is a fear that an Eisenmenger syndrome will develop. So we have to do catheterization and urgent operation. Child with sudden choking with peanuts received 2 rescue breaths but no chest rise. According to so child with sudden choking with peanuts received 2 rescue breaths but no chest rise. According to BLS guidelines, give 2 rescue breaths. So pediatric foreign body treatment. Pediatric foreign body in the foreign body airway obstruction treatment. So what do we do? If there is effective cough, encourage the child to cough. Continue to check for deterioration and or ineffective cough until obstruction relieved. So if the child has an effective cough, we will encourage the cough. Continue to check for deterioration to ineffective cough or until obstruction relieved. If the child has an ineffective cough, then we have to check whether he is unconscious or conscious. If unconscious, open airway, give 5 breaths, start CPR. If conscious, 5 back blows, 5 back blows, 5 back blows and 5 thrusts. Chest for the infant and abdominal for the child more than 1 year. Okay. So now let's go back to our question. Our question is child with sudden choking with witness received 2 rescue breaths but no chest rise. So child with sudden choking with peanuts received 2 rescue breaths but no chest rise. According to BLS guidelines, we'll again give 2 rescue breaths. Next, 3 days old neonate present with tachycardia, tachypnea, shortness of breath, and refusal of feeding. Is a 3 days old neonate. Tachycardia, tachypnea, shortness of breath, refusal of feeding, and hepatomegaly. Short systolic murmur. There's not mentioned as cyanosis or SpO2. So 3 days old neonate, this tachycardia, tachypnea. Hepatomegaly. So transposition of great arteries, tetralogy of Fallot, usually there will be cyanosis. So since there is hepatomegaly, it will be a patent ductus arteriosus with significant left to right shunt. Since there is hepatomegaly, refusal of feeding, tachypnea, tachycardia, the child is in heart failure. It looks like PDA with significant left to right shunt. Transposition of great arteries will have cyanosis. Tetralogy of Fallot will have cyanosis. ASD will not present with heart failure. So there is significant left to right shunt here. So from the PDA, the blood is going to the right side of the heart and then there is backflow. That's why there is hepatomegaly. PDA. The answer here is the PDA. PDA with significant left to right shunt. TGA, transposition of great arteries, does not have have murmur if heard may be for VSD. Hmm. 1 year, 1 year old, 1 year old rheumatic heart disease, fever since 1 month, no joint swelling, no chorea. Year old with rheumatic heart disease, fever since 1 month. Fever since 1 month, no joint swelling, no chorea, plus new murmur. Infective endocarditis. Causative organism. The most common causative organism of infective endocarditis is Streptococcus viridans. The most common causative organism of infective endocarditis is Streptococcus viridans. Rheumatic valve with a new murmur. Okay. Rheumatic valve with a new murmur, ESR 55, fever 39 for 2 weeks, ASOT titer, ASO titer 80, diagnosis infective endocarditis with Streptococcus viridans, subacute disease. Cause of rheumatic fever developed, case of rheumatic fever developed new murmur plus fever plus dyspnea, infective. The case of rheumatic fever developed new murmur plus fever plus dyspnea. It is infective endocarditis due to Pseudomonas organism. Due to Pseudomonas organism. But if it is rheumatic heart disease with new murmur, ESR 55, ASOT 80, then it is infective endocarditis with Streptococcus viridans. Okay. Same question here repeated. Rheumatic valve with new murmur, ESR 55, fever 39 for 2 weeks, ASO titer 80, diagnosis infective endocarditis with Streptococcus viridans, case of rheumatic fever, developed new murmur, fever plus dyspnea, it is infective endocarditis due to Pseudomonas organism. Case of infant 1 month old with slant eye, single palmar crease, diagnosed Down syndrome. Most common cardiac problem is the endocardial cushion. Endocardial cushion, superior QRS and left axis. Superior QRS and left axis. Okay. There is different question here. Preterm preterm 2 days with symptoms of heart failure. Preterm 2 days with symptoms of heart failure, hepatomegaly. There is heart failure. He is a preterm 2 days with symptoms of heart failure. There is hepatomegaly. Right parasternal heave. It is PDA. Child with ECG, supraventricular tachycardia, heart rate 210, respiratory distress, irritable. What to give? Adenosine. Bete congestive heart failure plus digoxin plus Lasix. What to give next? Captopril. Newborn with bradycardia for another. Newborn with bradycardia with rash on her face, arthritis, complete heart block, SLE. Newborn with bradycardia with rash on her face and arthritis. There is features of complete heart block, then it is SLE, SLE, SLE. Next, baby in NICU has heart rate 300. Good BP. Okay, baby in NICU has heart rate 300. Maybe this is SVT, but the BP is good. What to do? Give a carotid massage. 3 years old child with tetralogy of Fallot. What drug not given in hypercyanotic spells? So 3 years old child with tetralogy of Fallot, which drug is not given in hypercyanotic spells is digoxin. Digoxin is not given in hypercyanotic spells. Okay, major criteria for infective endocarditis is the typical finding in echo. Typical finding in echo. One of the following is not useful in patients with atrial fibrillation and stroke. One of the following is not useful in patients with atrial fibrillation and stroke. Systolic murmur preceded by a click. Mitral valve prolapse. Apical systolic murmur preceded by a click is a mitral valve prolapse. Fistula after tetralogy of Fallot repair, we need to give IV triaxone. Fistula after tetralogy of Fallot repair, we need to give IV triaxone. And fistula may be in coronary or in pulmonary arteries. Okay, after tetralogy of Fallot repair, fistula, we need to give IV triaxone, and fistula may be in coronary artery or in a pulmonary artery. Okay. Endocardial Cushing defect, ECG. What are the ECG findings? Superior QRS with left axis deviation. Superior QRS with left axis deviation. What do we see in the endocardial Cushing defect ECG? Superior axis with left axis deviation. Superior axis with left axis deviation. Child presented to ER with septic shock and took 3 shock saline. Now he is in PICU and adrenaline and dopamine infusion. GCS is 10. What to give? IV cortisone. Okay, now child presented to ER with septic shock. We give 3 doses, 3 doses of salines. Normal saline, 20 ml per kg or 20 minutes. Now he is in PICU and he is on dopamine and adrenaline. GCS is 10. What to give? It is IV cortisone because this looks like ionotropic resistant. This looks like ionotropic resistant. See, child presented to ER with septic shock, took 3 shock saline. Now he's in PICU, he's on dopamine and adrenaline. Still the GCS is 10. What to give? We give IV cortisone. We give IV cortisone because this looks like ionotropic Resistant. This looks like anotropic resistance. Case of transposition of great arteries with small PDA. Case of transposition of great arteries with small PDA. What to give? Okay. We need to keep the PDA open. In case of tetralogy, transposition of great arteries, we need mixing of blood. In case of transposition of great arteries, we need mixing of blood. So, we need to keep the small PDA open. So, we'll give prostaglandin E infusion to keep the PDA open. Okay. Preterm 2 days old with symptoms of heart failure. 2 days old with symptoms of heart failure, hepatomegaly, right parasternal heave. It is most probably PDA. Symptoms of heart failure, hepatomegaly, and right parasternal heave. It is most commonly PDA. Newborn 2 days old has hepatomegaly, respiratory distress, short systolic murmur, minimal cyanosis. Mainly PDA. Prostaglandin best answer, more effective in preterm than in full term. Infant with septic shock resuscitated. Infant with septic shock resuscitated. Capillary refill in 6 seconds. In slow capillary refill, give IV adrenaline. Then continue as infusion. With no response, IV hydrocortisone. See, there is septic shock. There is septic shock. Capillary refill time is 6 seconds. We give IV adrenaline. So there is a septic shock. Before also we had the same question. Septic shock, 3 shock salines given and admitted in PICU, given adrenaline and dopamine, but no response. So IV cortisone is given. Similarly here, infant with septic shock, capillary refill is 6 seconds, given adrenaline and you see no response, then you will consider IV hydrocortisone. WPW syndrome associated with Epstein anomaly. So, what is the surgical correction here? Surgical consultation. You will do radio frequency ablation of accessory pathway. Antiarrhythmic drugs to slow accessory pathway conduction. Newborn skin cyanosis relieved by warming cutis marmota. Newborn skin cyanosis relieved by warming cutis marmota. Bone skin cyanosis relieved by warming cutis marmota. Case of SVT, case of supraventricular tachycardia, hepatomegaly, picture of heart failure. So this is a unstable case of SVT. There is hepatomegaly, there is picture of heart failure, there is hepatomegaly, and there is picture of heart failure. So we will give direct cardioversion. What is the most commonest congenital heart disease? The most commonest congenital heart disease is the VSD. 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 Child after accident resuscitation started, but no response. After few minutes, ECG connected. After that, ECG. Child after accident resuscitation started, no response. After few minutes, ECG connected. After that, ECG showed pulseless electrical activity. Mm. Correct the causes. Correct. Start CPR and correct the causes. Start CPR and correct the causes. Start CPR and correct the causes. 5 H's and 5 T's. What is the most okay? Child presented with signs of congestive heart failure. Child presented with signs of congestive heart failure, developed convulsion. CT showed hydrocephalus. Child presented with signs of congestive heart failure, developed convulsion. CT showed vein of Galen. Vein of Galen. Signs of congestive heart failure, developed convulsion. CT showed hydrocephalus. The cause is vein of Galen. Vein of Galen. Vein of Galen malformation is a type of rare blood vessel abnormality inside the brain. In vein of Galen malformation, mishaps arteries in the brain connect directly to the veins. Mishapen arteries in the brain connect directly to the veins instead of connecting with the capillaries, which help slow blood flow. This causes a rush of high pressure blood into veins. The extra pressure in the veins can cause number of problems. The rush of blood towards the heart and the lungs forces the heart to work overtime to get the blood into the rest of the body. This can lead to heart failure in some infants. Blood pressure in the arteries from the heart to the lungs may rise, causing serious condition called pulmonary hypertension. High pressure in veins can prevent the infant's brain from draining adequately. Widespread brain injury sometimes causes severe loss of tissue in the brain. Some infants can develop hydrocephalus enlarged head if vein of Galen malformation blocks normal flow of the fluid in the brain. If not diagnosed and treated early, vein of Galen malformation can cause severe problems, may even be life-threatening. A 4 days old neonate came with refusal of feeding, picture of heart failure, short systolic murmur at the apex. He did not mention cyanosis. So 4 days old neonate, refusal of feeding, picture of heart failure, short systolic murmur at the apex. It is PDA. Child came to ER unresponsive. No pulse. ECG shown below. Defibrillation as it is VF. Okay. 8-year-old male is brought with history of sudden onset of giddiness and fall, from which he recovered in few seconds. His clinical examination was noted to be normal. Identify this ECG. Prolonged QT syndrome. What is the complication associated with this condition? Syncope and sudden death. Syncope and sudden death. What is the drug of choice for this diagnosis? What is the drug of choice for the diagnosis? Beta blocker, melicitine. Beta blocker, melicitine. Beta blocker, melicitine. Enlist two non-pharmacological treatments for the same pacemaker. We can be pacemaker, left cardiac sympathetic denervation surgery, left cardiac sympathetic denervation surgery. ICD may be intracardiac device. Avoid enlist two non-pharmacological treatments for the same is the D. Then avoid drugs that cause prolongation of QTC. You should avoid drugs that cause prolongation of QTC in this patients like erythromycin. There is a long list. E hyperkalemia. What is E? I don't know. E question is not given here. So identify this ECG. This ECG is a prolonged QTC. What is the complication? Syncope and sudden death. What is the drug of choice for this diagnosis? What is the drug of choice for this diagnosis? Beta blocker. Beta blocker and melicitine, mexiletine. Then what are the two normal pharmacological is the pacemaker and ICD and left cardiac sympathetic denervation surgery, left cardiac sympathetic denervation surgery. Avoid drugs that cause prolongation of QTC. One of the drugs is the erythromycin, but there's a long list of drugs which you should know. And maybe what is hyperkalemia? I don't know. In giant A wave, incomplete heart block, we see Canon A wave. In tricuspid regurgitation, we see large V wave and constructive pericarditis, we see steep Y descent. In pulmonary stenosis, we see giant A wave. In complete heart block, we see Canon A wave. In tricuspid regurgitation, we see large V wave. In constrictive pericarditis, steep Y descent. Case of septic shock, perfusion more than 4 seconds. What to expect in clinical exam? Cold extremities. Case of septic shock, perfusion more than. ECG shows ventricular tachycardia. What to give as emergency? Calcium. If it is torsidis points. Calcium. Okay. ECG and abnormal. ECG and abnormal sensation. Peak T wave, hyperkalemia. ECG abnormal sensation, peak T wave, hyperkalemia. IV calcium infusion first to stabilize cardiac muscle, then IV insulin and glucose. First to stabilize cardiac muscle, we give IV calcium gluconate. Then we give IV insulin and glucose. Scenario of child with stroke and hydrocephalus. Due to scenario of child with stroke and hydrocephalus due to now child has congenital heart failure due to vein of Galen rupture. Scenario of child with stroke and hydrocephalus and has congenital heart failure due to vein of Galen rupture. Vein of Galen rupture. Scenario of child with stroke and hydrocephalus due to ICH, now child has congenital heart failure, vein of Galen, rupture. Neonate with congestive heart failure. Neonate with congestive heart failure, give diuretic. Neonate with congestive heart failure, give diuretic. But still tachycardic attack, what to give? Captopril. Neonate with congestive heart failure, given diuretic. But still tachycardic and tachypneic, what to give? Captopril. Neonate with congestive heart failure, give diuretic. Tachypneic, give captopril. All of the following are true of cardiac tamponade except all of the following are true of cardiac tamponade. MRI is the investigation of choice. MRI is not the investigation of choice for cardiac tamponade, so it is not true. 12 years old boy, length 115 centimeter, with 12 years old boy, length 115 centimeter with systolic murmur and weak pulse. 12 years old boy, length 115 centimeter with systolic murmur and weak pulse, aortic stenosis. Williams supraventricular aortic stenosis, maybe. Major finding in Duke criteria for the diagnosis of endocarditis include major findings in the Duke criteria for the diagnosis of endocarditis include all of the following except Osler's node, blood culture and nutrition. So Duke's criteria, major typical culture findings, 2 positive culture of typical organisms, persistent positive 12 hours apart, drawn 1 hour apart, typical echo finding, positive results with predisposing cardiac condition, pyrexia more than 38 degrees C. One-year-old baby with cyanosis and failure to thrive, weight 6 kg. 1-year-old baby with cyanosis and failure to thrive, weight 6 kg, had murmur over left sternal, grade 3. What is the best treatment? 1-year-old baby with cyanosis, failure to thrive, weight 6 kg, had murmur over the left sternal border, grade 3. Do surgery and the weight is 9 kg. Weight is 9 kg. Child, delayed capillary refill time, low blood pressure, tachycardia. Low blood pressure, tachycardia. You gave 20 ml per kg bolus IV. Still no response. Next, repeat 20 ml bolus 3 times. Child, delayed capillary refill time, low blood pressure, tachycardia. You gave 20 ml per kg bolus IV. Still no response. Next, repeat 20 bolus 3 times. 3-month-old, 2 days fever, cough, developed tachycardia. 3-month-old, 2 days fever, cough, developed tachycardia, heart rate 210. ECG sinus tachycardia with P waves, hepatomegaly. Treatment, digoxin. Tachycardia, not SVT. Treatment, beta blockers or calcium channel blockers. Maybe heart failure. Maybe heart failure, and treatment is digoxin. SVT more than 220. 3-month-old baby, 2 days fever and cough, developed tachycardia, heart rate 210. Tachycardia. ECG sinus tachycardia with not SVT, ECG, sinus tachycardia use digoxin, tachycardia, not SVT. Is beta blockers or calcium channel blockers and maybe heart failure, we will consider digoxin. In third day post-operative day, in the third day post-operative day, a child solution sodium level is 124, is on intravenous. Child third day post-operative day, child sodium level 124 means hyponatremia. Hyponatremia is normal saline correction, 6 into target deficit, 6 into parts of carbon. Give saline, normal saline. In the third day post-operative day, child. Case of congested neck veins, muffled heart sounds, hypotension, tachycardia. Round baby developed cyanosis after birth, which is not improved by 100% oxygen. Examination, general central cyanosis, saturation 65%. CVS hyperdynamic effects, posterior manual best on the left sternal border, chest X-ray shows cardiomegaly with pulmonary tetralogy of Fallot. Why not? What is the ECG shows right atrial enlargement, means tricuspid ataxia. Baby developed cyanosis after birth, which is not improved with 100% oxygen, means mostly it is cardiac. Central cyanosis saturation 65% with 100%. Cardiac hyperdynamic effects, pansystolic murmur, best heard over the left sternal border. Chest X-ray shows cardiomegaly with pulmonary oligemia. ECG shows right superior axis with right atrial enlargement, probably tricuspid atresia. Diagnosis tricuspid atresia. Cyanosis in the first week. Cyanosis in the first week with left axis deviation. Cyanosis ECG shows superior axis with right atrial. That is cyanosis in the first week with left axis deviation is tricuspid atresia. Left axis deviation in acyanotic heart. In an acyanotic heart could be VSD, AVSD, could be VSD, AVSD, PDA, and coarctation of aorta. Left axis deviation in acyanotic heart could be VSD, PDA, and coarctation of aorta. Right axis deviation in a cyanotic heart. Right axis deviation in a cyanotic heart will be tetralogy of Fallot, transposition of great arteries, and Eisenmenger syndrome. Left axis deviation in a cyanotic heart is tricuspid atresia. Left axis deviation in a cyanotic heart is tricuspid atresia. Left axis deviation. That is tricuspid atresia. Right axis deviation in a cyanotic heart is tetralogy of Fallot, transposition Left oxygen. Coarctation of aorta.